Look at this, Renee. I think I'm in a different location today.
You are, again, somewhere else.
I
Typically, you're
am
not. Here you
somewhere
are.
else. No question about that.
Well, do you have like people walking past you and stuff today, or are you in a quieter spot?
Well, I picked it's the upstairs location overlooking the breakfast area of the conference hotel. So I think I'm okay. I had to turn the cartoons down on the TV, and I have a bunch of Connect 4 boxes underneath my laptop here. So it's a very professional setup here at
Very
the
nice. Very
conference
nice.
hotel.
I like it. So today we're talking about the Arizona Rural Health Conference. He's in Flagstaff, Arizona. It's still rural in the Southwest. We'll be talking about that today, some of the topics and the themes that we see now across the country, and getting into some data for Arizona that we haven't done that before, and some stories that you're not going to want to miss. But before we do all of that, what is going on the farm?
Well, I recognized it. I know it rained on the farm last night. I've been watching my weather station on my phone, but it rained here in Arizona in middle of the desert. And we talked to some folks here. It's the first time it's rained in 6 or 8 months in some of the
Wow.
locations it rained. So we thought it was really brown driving up here from Phoenix. It was really brown because there has been no rain or moisture for over 6 months for most of this area. So the rain was quite a blessing for a lot of people. And so that was the highlight of conversation.
Right. Wow, that's a lot. So, while you've been there, did you see the canyon?
Of course, we saw the canyon in a torrential downpour, and so
Oh, good
if you're
times.
if you're friends with me on Facebook, or I'm sure that picture will make its way to Rural Policy Partners eventually. Brett and I made a nice video at the rim of the canyon just to make it all worthwhile. It was one of those things you drove an hour and spent 10 minutes in a torrential downpour and jumped back in the Jeep and came back. So we didn't have the top down on the Jeep. I can tell you that, Renee.
You'd have
Um,
been pretty wet.
would have
Pretty
gotten
wet.
quite wet. So
All right. So today we're going to talk about a few topics that you've been kind of walking through. So those topics, we're going to just list them for you, then we'll kind of walk through them. But talking about how to change systems, age-friendly health systems, and how there's some federal criteria that we got to cover by 2026. I'm interested to learn more about that. Recruiting providers, kind of getting them to stay, isn't that a nationwide issue? And then mobile crisis. I hears like you've learned a lot on those topics. So the first one about how to change systems. What did you learn about changing systems?
Well, I can't say that we learned anything new, Renee, right? Because that's what we do. We've walked through the steps of changing systems a lot, but what we're finding more and more is, especially as we see the funding from the federal government change and the funding in the states change, we see more foundations stepping up in the space of community health, of really, putting more and more time and effort into what they can do to start changing policy, changing practice within communities. And so we see a lot of really great grants out there from these private foundations doing really important work to help support the healthcare infrastructure. And so we went to a really great presentation that kind of just helped us, reminded us about the 6 conditions of system change. And just for a minute, I just want to walk through them, right? At the first, structural change is policies, practices, and resource flows. And then it's about relationship and connections and power dynamics. And that's really where we spend our time, right, Renee?
Mhm.
And then if all of those things are happening, that's what causes transformational change, right? That's what changes us and that's what changes hearts and minds. And it was a good reminder as to sit through that and kind of walk back so we can better explain it to people. Because I think sometimes we jump in or we get called to a project and jump in. And sometimes it's really good to start at the very basics because I think a lot of people have forgotten. I think that, over time, people get so complacent and just kind of stuck in their own little way of doing things that we really have to get back to basics to help explain to people where we start and where we're going and what that means in the long run.
Yeah, it really gives people a better idea if you give them a purpose as to why you're talking about
Yeah.
change, because nobody likes change for change's sake, right?
Mm.
And so many people, I mean, we're talking about the current administration, whether you're a fan or a foe, it's a lot of change and it just
Yep.
keeps coming and there's no explanation behind it. So it makes it hard to sell, makes it hard for buy-in, makes it hard for people to be excited about the change. And so really thinking about that process, and I know you and I forget that not everybody knows change process like we do. So you forget that people may not understand that this is part of the process. So yeah, you're right. I have to remind myself of that, just even small changes in the office that I want to make, kind of like this is where we were, this is where we're going, and this is why. And I remember this ties back in my brain to when we were redesigning the mental health system. Nobody liked it the way it was, but man, as soon as you started to
Right.
change, there was all that resistance. And I had to keep reminding them, we're not going backwards. Nobody liked it the way it was, but they forgot because it was more comfortable to go back than to change. So it's really important to kind of get that in perspective. So that makes a lot of sense. So then the next topic you were kind of talking about was age-friendly health systems. So what is that about? Is that geriatric, I think you told me? So what are we talking about in that space, and what do we have to do by 2026?
Medicare comes up, and Medicare is a huge issue as we talk about critical access hospitals and rural health care, right? And we also have to think about behavioral health care of that population because that's often something that's unspoken. And so as we start looking at some of these age-friendly health systems that are going to be required to be in place as Medicare providers move forward, I haven't dove into it a lot. And I think if you work in the geriatric population or you're thinking about how do you really serve your entire community, you really need to be digging into this and thinking about how do you do it. It's not rocket science, but it's a framework. And I think it's a really good framework that everyone should be aware of. Just like we know that kids need pediatricians and pediatrics is very different, the same thing is true with geriatrics. And we have to
Mm.
stop putting everyone kind of in the same system and expect the system just to recognize that there are specialties throughout the entire system. And that's not just healthcare, that's also behavioral healthcare and addiction treatment and prevention and how our communities need to align around that. And so I just wanted to throw it out there. And it's probably something we could do a whole podcast about in the future of really digging into this and helping to explain it to people because I think it's something that's more important than we've talked about in the past.
That's a really good idea. We could probably bring on some guests that are specific in that
Yeah.
geriatric space. I know you and I both know the former lead of the aging division of
Yeah.
HHS, and would probably be really interested in talking about that some more. So that's interesting. And whenever there's a federal guideline or a federal deadline like that out there, change is going to come, but you may not actually hear
Hmm.
about it on the ground. And so it would be
Right.
probably pretty good to connect those dots. So the next topic you were talking about is just recruiting providers and incentivizing them to stay. You mean Arizona struggles with that too? That is shocking.
It's interesting. It's a huge issue here. 34% of physicians in Arizona are retirement age today.
Oh, wow.
So you're looking at like 1,200 primary care physicians are needed in the state. Every sector, every part of the healthcare system is seeing a deficit in folks coming into that field as to what's projected to be needed. So it's a conversation of what do we need to do, and what we're seeing. OIG, federal regulators are now turning, they used to be big hospitals they would go after and look at compensation packages and was it fair or, was it unequitable? They're now moving to rural hospitals. And so rural
Mm.
hospitals were always kind of out on their own. And so they would just pay a doctor, they just negotiate something and pay whatever they wanted. And what happened was there wasn't always a lot of consistency. CEOs
Right.
would come and go, and so it was interesting. We were talking with another consultant. She said, we go into hospitals, we say, where's the physician's employment contract? Well, that was 20 years ago. We don't even know what the contract is. We just know we have to give him 3% more every year.
Oh,
And they don't know what it's based upon. And so they find these huge variations between the new
wow.
person that came in and someone who's been in the community for 20 years. And so, we saw the same thing in behavioral health, right?
Yeah.
When I used to create incentive programs for therapists, it's a really big deal because now, there's a lot of regulation around those
Mhm.
things. And I don't think everyone understands the risk around that. And whether you're a hospital, a behavioral health provider, you really got to think about that. And there's a lot of rules and regulations around medical director. And I know being part of organizations and talking about this, it's really hard for some smaller organizations to have the legal insight that they need to develop out those things. So, it's something that we don't deal with a lot, but we deal with a lot of organizations that struggle with this. And so it's something I think that we can help bring up as a risk management issue and help provide people more tools for that.
Yeah, well, I mean, it didn't take very long for me to think back, and you might have forgotten, but one of your regional contracts you were working with, you had a particular provider that hadn't made their budget in what, 10
Mhm.
years? And
Yep.
part of that was exactly this, right?
Yep.
It was
It
paying
was.
people more
Yep.
and then not requiring them to do a particular
Yep.
amount of work to
Yep.
equal the amount of pay they were getting. So they
Right.
weren't getting the output of work and they didn't have any kind of requirements. And
Yep.
so they could have whatever caseload and kept getting that probably annual bump for their
Mhm.
salary while doing less and less work. And
Yep.
so it is an absolute in the behavioral health world, but also in those smaller hospitals, even in probably in some other bigger institutions where people have just always gotten what they've gotten. And you don't sit back and think, okay, what is the output or the
A-
product I'm getting?
And how do you tie quality to that
Absolutely.
payment,
Absolutely.
and how do you tie health of the entire organization to that payment, right? Because the organization does well in the year, then you can create a system where everybody wins on that. But if something happens that's bad, then everyone has downside risk as well. And that's not a bad thing as well, because that's how you get investment into the organization. That's how you get everyone pulling in the same direction. And that's where strategic planning and making sure everyone shares the same vision and mission is critical to being successful.
Yeah. So the last topic we wanted to hit on was mobile crisis. And, we had that conversation in Alaska that included a four-wheeler for mobile crisis. And so can't wait to hear what Arizona does in the desert. I'm sure it's going to be good. But you were saying, I think you told me that there's like one entity that really does the state. Is that kind of how that works? Talk to me about how mobile
Well,
crisis.
so there's one call center that operates 988 statewide. So everything flows through them. They dispatch then a mobile crisis using a network of providers, which is similar in other states. One of the things that intrigues me is Arizona only has 15 counties.
Hmm.
So you kind of have to conceptualize things just a little bit differently here, geographically, because counties are huge, and so some of the areas are not much population, right? Most of Arizona is in two of those counties, or most of the population in Arizona is within two of those counties, Maricopa. And so you think about, how do they reach people? And I asked, well, does it work here? And a lot of people said mobile crisis works really well. Sometimes that's the only thing that works,
Ooh.
because they don't have providers in areas. But they said that is something they do really well. And Arizona for years has been on the front end. We've seen a lot of the law enforcement programs. If you think about the HBO show, or Joe and Ernie, remember the officers that created some of those systems for diversion, mental health specific units. A lot of that work started here in Arizona. So, it doesn't surprise me that mobile crisis is going pretty well. I mean, there's challenges like anywhere, but it was kind of encouraging to hear that they have figured out, and a lot of providers do put a lot of time and investment into the mobile crisis system.
Yeah. And if you remember way back when we did that national project with NAMI for
Yep,
988, when it was first rolling out,
that's right.
Arizona was one of the constituents on that call. And they were talking then about the challenges rural versus urban in 988. So it's not surprising that you're telling me that they're really ahead on this, because even on that conversation, Arizona already had the statewide 988, like you just mentioned. And so they were further ahead when you and I were trying to bring all the states together in those provinces on the conversation of what
Right.
are we all going to do for 988. Arizona already had a plan where other states were still fighting over, is it going to be 911, is it going to be 988, what's the handoff, all those things. So you're right, that makes a lot of sense. So it's good to hear that it's actually working. Third leg, maybe not so much as far as the place to go, right?
Yeah, and there's some interesting dynamics that we kind of researched while we were here. There was legislation passed, I think, almost 3 years ago now, to build 5 locked residential treatment facilities across the state, 15-bed locked facilities, similar to what we saw. There's one in Nebraska that we kind of became acquainted with when we were doing work over there. There was a lawsuit from the ACLU. Those never were opened. They were ground
Oh,
was never broken, but the
wow.
funding's still there, and it's still in legislation. So we're not really sure what the next steps are for that, but that was trying to create some lower levels of care outside of acute care hospitals for folks who are difficult to treat, with complex needs. And so there are some of those things where we see the continuum issues here, right? You see the issues within the continuum of care, like we see in every state. And although, they were trying to get ahead of that 3 or 4 years ago, passing legislation that never came to be.
Wow. That's unfortunate. So now let's flip over to data. It sounds like you found a dashboard that you actually like. Talk to me about that, because most dashboards are very not very helpful and
Well,
kind of dated a lot of times, but you're saying this one's actually pretty good. So talk to me about what'd you find
Well,
and what's
Renee,
Arizona doing?
all of our work with state hospitals, whenever I go to a state, I kind of know where to look and what rock to look under to get more information on, well, how's the state hospital function here? We happen to click onto their hospital dashboard. And I have to say, I really like the transparency of the information they share in that dashboard. And so I don't have many screens in front of me right now. I'm just doing this from memory, but you can go to that dashboard, and we'll put a link in our show notes just so you can kind of see an example. And it has admissions, it had diagnosis, it has throughput metrics. It even has a tab that tells you who all was at the transition planning for that person to leave the hospital. And it includes somebody from the managed care company. It includes a case manager. It includes a family member. And they have upwards of 80% of a lot of those metrics show up to help with the case management and planning for that person to leave the hospital. And that's oftentimes where we see the barriers, right? Nobody shows up,
Mhm,
nobody has a plan,
mhm.
nobody's working together to integrate that person back into their home community or the next step to a lower level of care. And so I think from those ways, at least they're measuring it so they can see gaps. In other places, we haven't even been able to get that data. When we worked in North Dakota, Nebraska, it was very hard to find data. And so I was encouraged by some of those data points, Renee.
Yeah. What I actually have it pulled up in front of me because I'm not mobile like you. And what I appreciate, there's actually some filters that make some sense. So one of the filters I really appreciate, they have a metric that actually pulls apart unique members rather than
Mhm.
just all together who shows
Yeah,
up. And that really changes your data. It
right.
changes it dramatically. So here's one piece that it changes. So the primary diagnosis for all is mental health. But when you
Mm-hmm.
look at it primary for just individual unique members, it's not. In
Hmm.
fact, it's number 3 on their list of primary
Hmm.
diagnoses. So you can tell, which we already know, but now they have the
Right,
data to back it up, right? That it's super users of the system
right,
that typically have that neurodivergent
right.
mental health issues are the cost driver of behavioral health. And so when you pull that out and look at individual members, it's still pretty high. It's still number 3 out of probably 10 on
Hmm.
their chart, but it's not as high. And other just regular factors for health when it's a
Hmm.
unique member drive the system. And so I appreciate that because we never see that data. And
Right.
you could even pull out just fee for service
Yep.
specific. And so lines of business, they have it pulled out. So you're right. There's some really good things about this. And the other thing I like about this website is it also pulls out the American Indian population
Yeah.
specifically. And you said there's some information about how many people that covers.
Well,
It sounds like a lot
so
of.
I mean, just remember 27% of the state is native owned. And
Oh, wow.
so, you have a large portion of the state. I actually sat in breakfast this morning with a quality improvement coordinator of a Native American hospital, the Native American hospital system here in the state. We had just been up in Alaska,
Mhm.
where we heard from the largest native owned health system in the country. And so it was interesting to hear. It was a 53 bed acute bed hospital where she does revenue flow management. And so we had a really nice discussion about how things function and what things look like. And on her mind, the biggest stress is Medicaid right now.
Oh,
It's
yeah.
it's the funding. You mentioned fee for service, but really, it's funding is
Right.
really going to be a deal breaker for some of these smaller hospitals. And that's not even a critical access hospital. That's a freestanding hospital. But without that Medicaid funding, and here in Arizona, they're looking at it could be 25% of the population loses their Medicaid in the next 6 months, depending on what happens federally. And their legislators are still in session. They
Yep.
haven't figured things out here yet, and so all of those things are at play.
Yeah. And there's an entire piece of this dashboard that's dedicated to American Indians and their specific needs. For those that may be listening that don't know, they're considered federal. And so that's different. It's not
Yep.
Arizona dollars, right? That's a
Yep.
federal government that oversees. But they can get services in the state hospitals as well. And so there's
Yep.
crossover there, but they also have additional funds and additional services. And so that is more like Alaska in a lot of ways as far
Hmm.
as the percentage of population and people. And I know that was
Yep.
part of that conversation back with 988. But as much as we'd love this dashboard, Jason, talk to us about the challenges with the dashboard that you find everywhere. Acronym soup. Let's talk about it.
Oh, the acronyms. We started the day out here yesterday talking acronyms. And, I started writing down on a list. You like to play acronym bingo where you start the bingo
I
card
do.
out.
I
Um,
do.
my favorite one is there's an acronym. They call it access. And it
Hmm.
sounds like access, but it's actually AHCCCS, which is the Arizona Healthcare Cost Containment System. And everything is housed, that's their Medicaid system. So everything is housed in the AHCCCS system, and it's called Access.
No, it's not.
It's not even pronounced that way. It's pronounced something different. It was so bad.
And it
And
means Medicaid. No,
it
it does. I mean, come on now, right? That's
Right. I
crazy.
mean, it's a fancy name. And then, it just goes downhill from there because everything, and sometimes it's an acronym. We love the AHEX. We see the AHEX at all the rural conference we're at. And so they put names in front of the AHEC because they have like 9 regional AHECs here. And so some of them have a dash between the pre-name. So it's the AZ dash. And then sometimes it's not, it's the native, but then it all runs together. There's no rhyme or reason to it. Sometimes letters are capitalized, sometimes they're not. Why do we continue to use acronyms when it
I
just
don't
makes
know.
it so hard for the general public to understand? It
No,
doesn't save anyone time at all. And so
no, it
again,
doesn't.
I get on my soapbox, Renee. When will people just start using plain, simple English to
I
explain
don't
what's
know. And
happening?
I don't know. And I looked at the dashboard this morning and I go to the about page to try to understand the acronyms. And then they threw in a new acronym that I still couldn't find. And when I go to find the name to that acronym, they threw in a different acronym to explain that acronym. So now I could go down a
You,
rabbit hole, I'm guessing, just trying to figure out the acronym.
you,
So
you, you
I'd be
know,
having a grand time with bingo in that state,
you,
sounds like.
in our home state, they just released a new acronym guide to the
Oh,
behavioral health system redesign because they're making up new acronyms
no,
and people
no.
don't understand it.
Oh,
And
no.
so the solution was not to decrease the number of acronyms or use the whole name. It was
No,
to create a new
let's
guide
create a new guide.
that we're going to
Wow.
send out with everything that goes out.
Wow.
Yes.
That's
Yes.
awesome. So I had a dashboard, Jason. I had a electronic health system record on my phone that worked pretty good. I liked a lot. And I
Mhm.
just learned between like a doctor's appointment and a follow-up appointment, they decided to change the entire system.
Yep.
So they shut it down the end of May for June 1st. And it's past the beginning of June when I'm recording this. And I'm here to tell you that it's blank. So
Yeah.
my entire health record is currently missing. I'm hoping it's somewhere, maybe on a cloud somewhere, but it's definitely not on my dashboard
Yeah.
anymore where I can see it. So this whole thing about dashboards, and you guys have heard how much my love for the one at corrections that I deal
Mhm.
with on a daily basis. These things will win awards for being such cutting edge and then they don't work. And that drives me
Yep.
crazy. I mean, because it's like this one, it sounds like a great dashboard that has real-time data. That's awesome.
Mhm.
But when it doesn't work and you can't actually access it, then it's not really a dashboard. I mean, it's
Yeah.
there but not there, which is mostly like the ones we have in our state,
Yeah.
there but not there.
They have to be maintained and they have to adapt and change over time as the data changes and the systems change and things are updated. And so these aren't just a one-time cost. And I think sometimes that's the hard part to explain to funders and those who are doing budgets is that this is an ongoing cost and it means it has to be updated on a regular basis, not just the data being updated on a regular basis or pulled or however it gets there, but the actual underpinnings of the system have to be upgraded and evolve as the systems evolve. And we know how quickly technology evolves. We simply have to recognize that this is where we need to put our time and energy because that's what's going to save us money in the long run.
And you have to realize that when you go live, it's probably not going to be the best, and you've got to prepare for that.
Right.
So it's like, is there ever an electronic health record a day and a time that you should go down? Probably not, but you know it's not going to be immediate. So I feel bad for these folks on the back end. I'm sure this is terrible for them because now this thing isn't working and whatever.
Right.
From a client's perspective, again, I was just going from this to following up my doctors, and I can't. So then I had to make a call, and then I played phone tag, and I made 4 calls and then all these things that could have been done if the
Right.
electric record worked and if I had
Right.
my system to connect, I could have done that. But no. So it's just frustrating for even the systems that are the good systems, the higher paying systems. I mean, they all have flaws. And so here we are. Before we leave today, I want to talk about the recovering politician self-care policy of the week. I am modeling a mental health day in my office. I just
That's
decided
amazing.
I'm going to take one because I can. And there's people in my office that probably should, but they don't have the vision. So we're going to model it. I have sick time to use, and I'm not physically sick, but mentally I'm a little off today. So I was like, you know what? I have a lot of things to do. So I'm just going to take the day. And it's been an interesting, just the conversation. I went around the office and told people, this is what I'm doing. I put it on the calendar as a mental health day. And so I've had so many questions about this, and they're like, are you feeling okay? I'm like, yes. And they're
Yeah.
like, and you're still taking a day? I'm like, yes. And you're calling it sick time? And I'm like, yes. And it's been really good because you have to model it. If you're in leadership and you are in an office, you can't expect others to realize or take or self-check if you don't self-check yourself, right? And
Right.
so last week, a couple last past weeks of some incidents occurred that made it really obvious that this is not going as well as it should be in the office. And some people probably should be taking time off, but they, want to be there for the team.
Hmm.
Well, not if you're not your best self, you're not really there for the team, and you're causing havoc in your wake. And so
Hmm.
people are getting harmed by you being present. You should not be there for those things. So I was like, you know what? How could I model that? How could I do it? So
Yeah.
it's new for me. I'm going to see how it plays out, but I'm pretty excited about it because it's not something that I've seen in the office. Just the conversations have been good. So we'll see. But sometimes you have to go first, and we'll see how it goes. But I'm doing it today. I had a lot of stuff to do. So I was like, I can't pretend like I'm going to work today. It's not going to happen. So I got things to do. But any
Yeah,
thoughts on mental health days?
I do. We should do a whole podcast on mental health days and how do you play at work, right? I mean,
Yeah, we really should.
when we get out of when we get out of a conference and it's 5 o'clock, we know it's going to be light for another 3 hours. We usually go do something fun.
Yeah.
It just doesn't make sense to go sit in a hotel room, and
No.
watch, HGTV, binge watch for 3 hours. There's things to do. And so even if it's, seeing the Grand Canyon in a downpour, it's still fun, right? And so part of
No.
it's thinking about how do you play at work, and then how do you take a step back when you need to take a step back and take
Yeah.
that mental health day. And I think that I know over the years I've learned the hard way that you got to find the balance and you got to find a way to play
Yep.
and have fun. And if you're not finding that sweet spot in your life where what you do is what you love, and you get energy from it, then you really have to reevaluate and figure out what do you need to do for yourself to help you through that time. And so,
Yeah.
that's why it doesn't get any better than this.
Right.
Bouncing around. We're taking the tops off the Jeep on the way back to the airport
Oh,
this
I
afternoon.
cannot wait to hear.
So
I
I'm
love the
gonna
picture
be,
you sent. So maybe we
oh
can post
yeah.
some more of those with the podcast because there's some good pictures.
That's how we play at work, right?
Right. That's how
So
you do it.
just take the
Well,
top off the Jeep. That's what the message
that's
we're
the
sending
answer
today.
to life's
That's
problems right
always the
there.
answer.
That's it. Well, today we talked about the Arizona Rural Health Conference. Jason's on live on site in Arizona. I didn't get to go this week. I was taking care of myself by not traveling, which is what I needed to do this week. And so, talking today just about a lot of different topics that were going on that are interesting out in Arizona that apply to us. Things like talking about how to change systems and working with age-friendly health systems and recruiting providers. We all talk about that and mobile crisis. So it's fun to see the things that are the same, but also what we learned and picked up that's different and new every time we travel to a new location. But before we go, please don't forget to follow us on LinkedIn or YouTube or Facebook. If you leave us a positive review, we'll send you a prize. Have a great day, everybody. We'll see you next time.